I am Valentin Fuster from New York, and it is a pleasure again to have 1 hour discussion with 4 professors here about the breaking trials of this virtual meeting. Is the meeting virtual exciting? Well, we'll try to make the trials exciting to you. And this is the plan that we have this morning or this afternoon or this evening for you. And at this first, we are going to address, as I mentioned, 8 different trials, and we will start actually like session by session. And we will start with session number 1 of this meeting. And I will discuss in a moment exactly the titles and so forth. But before I go any further, let me introduce my colleagues here, very well known by you, and Dr. Lynne Stevenson is Director of the Cardiomyopathy and Heart Failure Program at the Vanderbilt University Medical Center in Nashville, Tennessee. We have Dr. Ann Curtis, who is the Chair of the Department of Medicine at the University of Buffalo, New York. We have Dr. Wayne Batchelor, Director of the Interventional Cardiology and Interventional Cardiology Research at the Hanover Hospital in Falls Church, Virginia. And finally, obviously, we need a surgeon here, and here we have it. Very well known to all of you, has been with us many times before, Dr. Michael Mack, Medical Director of Cardiothoracic Surgery for the Baylor Scott and White Health, and the Chairman of the BSW, the Heart Hospital in Plain Research Center in Texas. Well, thank you very much for you joining me in these discussions, and I hope we have fun. And now we are going to go into the titles of the presentations, the ones I thought were interesting on the first session. If we'll discuss PARADISE-MI, the role of ARNI and in post-MI low ejection fraction, the LAAOS-3 trial, left atrial appendix closure by the surgeon to prevent thromboembolism. And then we'll go into the ATLANTIS, very interesting antithrombotic therapy in TAVR, where we are going. So let's begin with the first study. That is, the study is the PARADISE-MI trial, or the title actually is Angiotensin Receptor Neprilysin Inhibition, or ARNI, following acute myocardial infarction, primary results of the PARADISE-MI trial. This was presented by Dr. Mark Pfeffer from the Brigham and Women's Hospital in Boston. Well, let me introduce the situation. And you know very well, in the 1990s, ACE inhibitors came in patients with heart failure, great results, decreased mortality. In the early 2000s, receptor blocker drugs came, like valsartan and so forth, great results also in heart failure, in terms even in mortality. And then more recently, we have the valsartan sacubitril combination, or ARNI, also great results in patients with heart failure. Well, but there is not much actually on patients during the early stages of myocardial infarction. And this is actually the study that we are going to be discussing in the next few minutes. And this PARADISE-MI study. This is a study actually of 6,000 patients with MI, and just let me say that 76% were STEMI and 24% were non-STEMI. And these 6,000 patients came actually from 41 countries. And basically, these were patients with an acute myocardial infarction within the first 7 days with an ejection fraction equal or less than 40% and or pulmonary congestion. These patients, about 6,000, were randomized into sacubitril valsartan twice a day, and ramipril. Actually, the sacubitril valsartan was 97, 103 milligrams respectively. Ramipril twice daily, 5 milligrams. So here we have the combination versus ramipril. Now, the follow-up was actually close to 2 years. It's not a long follow-up. And actually, the primary endpoint is combination of cardiovascular death, heart failure hospitalization, and outpatient development of heart failure. All right. And And here we are. If you really look at the primary outcome, I'm sorry, as I mentioned, with cardiovascular death, first heart failure hospitalization or outpatient heart failure, the results were very close with both groups, 7 point per 100 patient years in the ramipril, 6.7 per 100 patient years in the sacubitril valsartan. But then there is a departure here. And what about what has been done in other trials? Not only to look at the first event, but the first event and recurrent events. And by doing that, then the results become significant in favor of the sacubitril valsartan. So with ramipril, there were 10.1 events per 100 patient years. And in the sacubitril valsartan, 8.4 per 100 patient years. So that's basically a difference with the other results. Then the side effects were actually very similar between both groups. And I'd like just to move into the conclusions. We will open this for discussion. And the conclusions are as follows. In a vigorously managed enhanced risk acute myocardial infarction population compared to active therapy with ramipril, sacubitril valsartan did not result in a significant lower rate of cardiovascular death, heart failure hospitalization, or outpatient heart failure requiring treatment. Number two, pre-specified observations of reductions in the total or recurrent events support incremental clinical benefits of sacubitril and valsartan. And finally, the safety and tolerability of both arms were actually comparable. So here we have a primary endpoint in which really it didn't work. And then we do what is now being done in a number of trials is to look at the first event and then subsequent events. And here the results became significant. Well, let me go now to just for some questions that I have for you, and I'd like to see your views. Lynne, what do you think about this trial?
So I think the Paradise trial basically demonstrates for us how incredibly effective ACE inhibitors are. They really changed everything. And on top of that, it would be hard to show a benefit. And I don't think we really showed one here. Even if we can readjust the endpoints, there's really just about one event per 100 that's prevented. And I see this as a largely negative trial. There may be subsets that might benefit, but I don't see this as an imperative to use sacubitril valsartan instead of an ACE inhibitor after an MI.
Except the follow-up was short. Anne, what do you think?
Yeah, I agree with Lynne. I think one of what we've seen is just how incredibly effective the drugs that we already have are. I mean, if you did this ARNI study against placebo, you'd see a huge benefit in terms of using it. But now that we've got these drugs that have been around for so long, it's hard to see much of a difference. And so, yeah, I agree with Lynne that it doesn't really push you towards using the combination. If the cost was the same in patients and there's maybe a little bit of a signal of a benefit, then maybe you'd switch over, but it's not a compelling argument to change course now.
Thank you, Wayne.
I also think it's really important to recognize that the post-MI population is very heterogeneous. Yeah. And they've just used Killip class, but there are patients who are hypoperfused, patients who are asymptomatic with a low EF. I think we need to look at these populations individually and not try to come up with one therapy for everybody.
Thank you. Wayne?
Yeah, I think the other message in this is how important it is to stick to the primary endpoint in evaluating clinical trials. I mean, we can do a lot of secondary analyses and slice and dice data to look at it. I think Dr. Stevenson's point was very important. When I'm looking at secondary or other endpoints besides the primary, I'm looking at the magnitude of difference as well as the statistical significance. And as Dr. Stevenson pointed out, the magnitude of difference was very modest. So as Dr. Curtis has pointed out, when you have an inexpensive drug that works, that's generic, this, in my opinion, is not enough to necessarily supplant that standard.
Thank you, Wayne. Michael, what do you get from here?
Yeah, I've got nothing further to add to what the other three have said. I totally agree.
Okay, well, thank you very much. Then let's move into the second one. The second one is really exciting. is the LAAOS study, LAAOS-3 study, which means left atrial appendage occlusion study. It was presented by Dr. Richard Whitlock, a professor of surgery at McMaster University. And let's go into some background into this. So left atrial appendage occlusion has the hypothesis that can prevent a stroke in atrial fibrillation. And this is, I don't think, it's a hypothesis, it's a reality. Based on a number of more recent studies, but we don't talk about surgery. Here we are talking about the surgical approach, and the author decided to use surgical closure of the left atrial appendix in trying to look at whether or not this led to a decrease in ischemic stroke or systemic emboli. Well, with this in mind, this is the study. Actually, it was a large study. 27 countries participated, and there were 5,000 patients. And these patients actually were randomized. These all underwent surgery. I will talk about this in a moment. But they were randomized on occlusion versus no occlusion. And this was by the different techniques available to the surgeons to perform such procedure. What is interesting is when we talk about surgery, what we are talking about, well, 20% of the patients actually had coverage, and about 65% of the patients had a valve procedure, not necessarily mitral. 35 mitrals were 35% were aortic. So it's all kinds of surgery. But what patients got into this study? This is very important because these patients are sick, frankly. In other words, for example, history of heart failure was in about 57% of these patients. And then permanent atrial fibrillation, 31%. In a CHA2DS2-VASc of an average of 4.2 was present also in a significant number of patients. So I think the question that we are dealing here is with a surgical approach on patients who undergo any type of cardiac surgery, who I believe at least are, I would say, are not trivial from the point of view of the disease that they have, are sick patients. Well, I go into the results now. The follow-up was 4 years, so it's a good follow-up. And the ischemic stroke or systemic emboli, most was ischemic stroke. We have an incidence of 4.8% in the group treated surgically versus 7% in the group treated that was not treated. And then we go into secondary outcomes. Well, in terms of mortality was the same, 22% in both groups. We talk about a 4-year of follow-up. And so with the data I presented, I think we have a very good feeling of what happened here. The surgical closure reduced ischemic stroke, I would say relatively by 32%. And these patients actually, most of them were treated with anticoagulation, 80%. So we have a situation that is quite fascinating to me. And that is, I have 2 patients today here that are going to be operated. One is a patient following a tetralogy of Fallot. It needs something to be done in the left side of the heart as well as on the right side. And another is a mitral patient. It requires a repair. This is this morning. And the question is, both patients were very sick, actually not very sick. But what I tell my surgeons what to do based on this trial. So Michael, tell us, what is you thinking?
So first of all, Dr. Fuster, this has been a quandary or a question without significant evidence that has existed in cardiac surgery for decades. And this is a strong evidence base that begins to answer the question. Because surgeons really haven't known what to do, and referring physicians haven't known what discussion to have with their surgeon. I think on balance, this does say that in patients undergoing cardiac surgery with a CHA2DS2-VASc score of 2 or greater, that you should err on the side of occluding the left atrial appendage. Now, this is not one size fits all. As you've alluded to, there's a lot of different types of surgery that was done here. And it did, and subgroup analysis, it did seem to be beneficial in all types of patients, including valvular and non-valvular atrial fibrillation. Now, there is the possibility of actually hurting patients, although there was no safety signal in this. So who shouldn't you do it in? Perhaps elderly patients with friable left atrial appendages, patients that are reoperative procedures, patients that are done through a minimally invasive approach. And although there's concerns of additional heart failure with ligation of the left atrial appendage, which is a rich source of ANP, there was no signal of benefit here, but I still would be cautious in those patients.
It's a change in paradigm, isn't it, otherwise?
This is a trial that has the potential to clearly, significantly impact and change clinical practice, yes.
Thank you. Wayne?
Yeah, I want to congratulate Dr. Whitlock and co-investigators for carrying out this study. This was a huge study, 105 centers, 27 countries. And to follow up Dr. Mack's comments, I think it does start to shift the needle. You know, there was a 32% relative risk reduction for stroke, translating into an absolute risk reduction of 2.2. So that's a number needed to treat 45 patients to save a stroke. And if you're in there anyway, and from what I gather, this doesn't seem to require a lot of extra complexity, then it does start to make sense. I thought there were some interesting observations here. One, most of the benefit started to accrue after 30 days. That's what you would expect for something like a stroke in the future, but the curves look like they continue to separate over time, suggesting a durability of effect here, which is an important observation because some of these left atrial appendage surgical closure procedures historically have not always lasted in terms of maintaining complete closure. There were a whole host of techniques used, and I want to congratulate them for also blinding the investigators and the research team. But there are a whole host of techniques used, and I'm not as familiar with all the different techniques, but it would be interesting to see over time if there's any sort of signal of one particular left atrial appendage closure technique perhaps showing a better promise than others. So I think in summary, this does start to shift the needle, and I think in patients who are at increased risk of stroke, again, CHA2DS2-VASc 2 or greater, I think this does make sense if the surgeons feel that they can do it safely.
Thank you, Anne.
Yeah, one of the things I noticed in the data that they showed is that they have, you know, there's still a fair subset of patients who aren't anticoagulated in follow-up. And these are high-risk patients who have known atrial fibrillation. So at 3 years in the two groups, it was 75 and 78%. I'm curious about where the strokes were and if they tended to be concentrated among the patients who didn't have continued anticoagulation. This wasn't available for this presentation now, but I hope that data comes out, you know, as they get this published. You know, because I think the concern I would have is you don't want people at this point to think that you can do the occlusion of the left atrial appendage and then everything's fine and you don't need anticoagulation. It should be emphasized that these patients remained on anticoagulation, yet there was still a good benefit seen.
Good point, Anne. Lynn?
Yes, I agree. I think this clearly shows the benefit, and what a tour de force to get it done. I don't think we've answered the question about whether this might worsen clinical heart failure. Half the patients in this trial had a history of heart failure, and yet at 3 years, the heart failure hospitalization rate was 7%. Impossible. So I don't think they got all the events that we would expect to see in this population. And so I think it remains an open question of whether there is an increased risk of heart failure events in some of the people who most need their natriuretic peptides.
Well, certainly a very interesting study. I think it will change practice, but many questions to be answered. And I think it's one of the most interesting actually presentations in this meeting. But let's move now into another presentation, and it's important. What do we do with TAVR? Wayne, I'm not asking the question yet, but what do we do with TAVR and all these antithrombotics that are around, you know? Let's go into the ATLANTIS study. Okay, the ATLANTIS study, or so-called antithrombotic strategy to lower all cardiovascular, neurological, ischemic, and et cetera, in the TAVR patients. This was presented by Dr. Jean-Philippe Colette from Paris. And I'd like to go into some background. I think it's important. And that is, what do we do today? Let's start there. And you know, there are two approaches: the patients who do not need anticoagulation for one reason or another, and then we use platelet inhibition alone, or patients who need anticoagulation and we use anticoagulants. Now here the trick was, one group or another, let's randomize either platelet inhibition or anticoagulation with actually, in this case, with apixaban. And this was actually the question that was being presented. Interestingly, there is a previous study, I think it was the GALACTIC study, in which rivaroxaban was used, and the results were not actually quite good. But let's now ignore those, and let's go into the study. The objective was to demonstrate superiority of apixaban 5 milligrams twice daily compared to standard of care. I already mentioned some are treated with antiplatelets, some are treated with anticoagulants, and certainly apixaban was actually looked versus the anticoagulation in one group versus platelet inhibitors in another. We are talking about a European multicenter study, 1,500 patients after successful TAVR. And I already said exactly how this was divided. I mean, a group of patients had anticoagulants versus apixaban 5 milligrams twice daily. And the other was apixaban versus platelet inhibition, different kinds of platelet inhibition. What about the primary endpoint? It's a composite of many aspects, actually. MI, death, stroke, systemic emboli, intracardiac bioprosthetic thrombus, and mesha bleeding over a period of 1 year. I'd just like to emphasize that one of the aspects was the identification of thrombi in the valve. And they use CT and echo. I think this is important. And in order to say the patient has a thrombus in the valve, it should be visible either with transthoracic echo or 4D CT, and should be a transprosthetic gradient of 10-20 millimeters, now go into details now, or a reducing leaflet mobility. This has been pretty standard on the definition of thrombus in these bioprosthetic valves, although frankly, we don't know if this is the way to do it. But anyway, this was the study. And now I'm going to be presenting the results, what was found. First, the group on anticoagulants. This is a group in which anticoagulants were compared with apixaban. Results, primary outcome, as I mentioned, exactly the same. 21.9% events, 21.9% events in the other group. I just want to be sure of one issue, is 1 year of follow-up, as I mentioned. Second, what about bleeding? Exactly the same, about 25% both. What about thrombus? Exactly the same, 0.9%, 1.3%. This is about the group with anticoagulation versus apixaban. Now comes the second group, platelet inhibition or no need for anticoagulants versus apixaban. What about the primary outcome? Well, 16% or 17% in the apixaban, 19% in the platelet inhibition group. What about bleeding? The same, 21% both. What about valve thrombosis? Interesting, 1.1% in the group treated with apixaban versus 6.1% in the group treated, with platelet inhibition. So in conclusion, we have a situation here that apixaban after TAVR procedure does not appear to be superior to standard care with anticoagulation in one group or with platelet inhibition in another group. The safety is the same. However, subclinical valve thrombosis is decreased in the apixaban group. I don't know exactly what this means, and I suspect these patients have to be followed for a long period of time to know what you see in the valve has clinical significance. But Wayne, you deal with this all the time. Tell me, what is your reaction to this study? Did you learn something?
Well, I learned something, but unfortunately it opens up even more questions, as do some of these trials that have these sort of heterogeneous results. I think, again, being a clinical trial purist, this was a negative study. It did not meet the primary endpoint, but there were some interesting signals clearly from the secondary endpoint analyses. I think, first of all, the first comment is this is an extremely confusing and difficult arena in which to sort of make decisions. We have, in some cases, advocates of single antiplatelet therapy after TAVR. Dual antiplatelet therapy is currently sort of the existing standard. And then, of course, with patients who might have indications for anticoagulation, it gets even more complicated. So I think what the take-home message for me is, number one, this does not supplant other prior gold standards for addressing antithrombotic therapy after TAVR. We're still confused as to what the gold standard should be, frankly, and I'll be curious to see what Dr. Mack has to say about that. But I think that number two, it was a safe approach. There's no safety signal with using apixaban in this manner, and that's reassuring. And then finally, there were pretty dramatic reductions in bioprosthetic thrombosis of 77% relative risk reduction. So my take-home message is, and also in DVT, it's a reduction. So my take-home message, and in patients in whom you're worried about bioprosthetic thrombosis, or you perhaps have Holter or some other indicators of concern, a trial of apixaban seems to be safe and might be effective in those scenarios. But I don't think it supplants our current approach, which is already somewhat confusing, heterogeneous, and unfortunately, this doesn't move us anywhere forward in that regard.
Michael?
So I agree with everything that Wayne has said. And I would add in addition that we know from other trials that when you do surveillance screening for valve thrombosis, which is the reason to anticoagulate these patients, that it occurs in anywhere from 25 to 30% of patients undergoing TAVR. Secondly, we know that it is not associated with acute clinical events. And thirdly, from the evidence that we know, there's no evidence that anything more than aspirin is beneficial in these patients. And we do know, as you've mentioned, Dr. Fuster, that the Galileo trial was negative for rivaroxaban, and also there was a safety signal. So what we learn here is that there is no benefit to apixaban over standard of care therapy, whether you're on oral, have an indication for oral anticoagulation or not ahead of time. But I do have some concerns about this study. First of all, there were 8 components to the composite primary endpoint, which is the most I have heard in a trial. And it combines an imaging component with clinical outcomes. And as we learned at the presentation, imaging data was either absent or invaluable in half of the patients. So I don't think, I think that is a significant concern. And secondly, we've seen that the incidence of valve thrombosis found in this is between 1% and 6% based upon whether you're on apixaban or not, which is much, much lower in other studies. So I think the conclusion of this is that there is no demonstration of benefit of apixaban, but I do have some concerns about the design and conduct of the study.
Thank you, Lynn. Comments?
No, I've learned a lot from this. I do think it's important to recognize that a minority of patients were in the requiring anticoagulation section. So this is really largely based on the patients who did not have other indications for oral anticoagulation.
Thank you, Anne.
Yeah, I think there's one positive spin I can put on this. I mean, I agree with the comments that have been made so far. But, when I have a patient who has already been established on anticoagulation because they need it for atrial fibrillation, I don't want to be stuck looking at a patient like this and saying, geez, we should take them off it and put them on platelet therapy or leave them the way they are. What this tells me is that if I had a patient who was already taking apixaban, for example, I don't do any worse keeping them on it. So the patients who have atrial fibrillation, just treat them with apixaban is the way it looks to me. And for the ones who don't have a need for anticoagulation, stick with the antiplatelet therapy.
Yeah, I was going to make the same comment. Apixaban is not so bad. After the rivaroxaban study, I was very low in NOACs in this, but at least in this study, Michael, apixaban, it doesn't do so bad. So if the patient is on atrial fibrillation, let's continue.
Sure. Yeah.
All right, thank you very much. We are going to look at session number 2 now, and there is a paper that I think is interesting, is not earth-shaking, but certainly is bringing again into the discussion the possibility of rivaroxaban, low dose, and aspirin in patients with atherothrombotic disease. And the study that we are talking about is the VOYAGER PAD trial, or total ischemic event reduction with rivaroxaban after peripheral arterial revascularization. And this study was presented by Dr. Rupert Bauersachs from the University of Mainz. And I'd like just to present it because it's an interesting new approach to antithrombotic therapy that maybe has some future. Well, there are 2 aspects here. The first is the original VOYAGER PAD study demonstrated that at 3 years, approximately 20% of patients undergoing low extremity revascularization, as we talk about today, a first adverse limb or cardiovascular event, despite of treatment with aspirin, was and statins and clopidogrel if necessary. It was 20%, as I say, decrease or demonstrated an increase in events, which was significant of these patients, 20%. This was at 3 years. The addition of rivaroxaban in the original study, 2.5 milligrams daily or twice daily plus aspirin, actually reduced these incidents that I mentioned by approximately 15%. What is presented today is that the same we discussed before. What about the total number of events that take place over a period of 3 years rather than as it was done before the first event? And this is basically the approach that is being taken in the study. And now I will be presenting the basic data. So in this VOYAGER study, which actually entail about near 7,000 patients actually, was randomized peripheral arterial disease patients undergoing surgery of the lower extremity. And they were randomized into rivaroxaban 2.5 milligrams twice daily plus aspirin versus aspirin alone. And the primary endpoint in the original study was the first event in terms of acute limb ischemia, major amputation of a vascular cause, myocardial infarction, ischemic stroke, or cardiovascular death. What is new this time is the same study, but the current analysis involves all events, first and subsequent, and in addition, vascular events including peripheral revascularization and venous thromboembolism. So results. What we have here is that rivaroxaban, together with aspirin, reduced total primary endpoints with an HR of 0.86 compared with aspirin alone, and also decreased the total vascular events. They say it's an estimated 4.4 primary and 12.4 vascular events per 100 participants were avoided with rivaroxaban over 3 years, 4.4 and 12.5. And so in conclusion, in symptomatic peripheral arterial disease patients undergoing lower extremity revascularization, they have a high total event burden these patients, and it appears that rivaroxaban plus aspirin is efficacious. The point I'm trying to make is that there are a number of studies now using this regime in native disease, in disease after intervention, which is rivaroxaban, very low dose plus aspirin. So I wanted to at least get the feeling from you people. Maybe Wayne, you can take this one too, since you because of the interventional aspect.
Yeah, thanks, Dr. Fuster. Again, not an out of the ballpark home run here. Number one, PAD and vascular disease is a significant predictor of cardiovascular events, and I think this study really highlights that. These event rates were quite substantial when you start following them over time. Number two, a driver of outcome is going to be a vascular event in this patient population. So that's an important observation as well. One of the strongest relationships here between outcome was whether patients had recurrent vascular events and needed more interventions. Number three, there is a modest reduction, obviously, in the use of, associated with the use of rivaroxaban in this patient population. We've seen that before. But we've also seen that this was associated with an increase in bleeding. So I think that when one looks at this, you have to sort of counterbalance efficacy with safety, and then also factor in cost. Right now, rivaroxaban is significantly more costly than the standard of therapy. So, I don't do a lot of peripheral interventions anymore, but if this was a patient that I was seeing, I would really have to look at the patient's risk of bleeding versus thrombosis, look at the insurance plan. I hate to say it, but we're asking these patients to take sometimes 10 medications. They're going to be on numerous medications, and if the pocketbook could only afford one other one, I would have questioned whether or not another class of medication would be perhaps considered. So I think it's a soft win, but it's not a game changer in my practice because of the bleeding concerns and the cost.
And in going about bleeding, and I agree, Wayne, this is the main concern. The TIMI measure bleeding increased by 43% in the group that was treated with apixaban combination with the drugs, the combination of rivaroxaban and aspirin. There were 62 events rivaroxaban and aspirin, and versus 44 events with aspirin alone. So I think it's an important point what Wayne is talking about. And what do you think about, I think we have to be very careful with bleeding. This is a new regime that is being used now in many aspects of vascular medicine, but I'd like your opinion.
No, it's true. The effect of the rivaroxaban does seem to be durable. So when you look at the curves and as they go out, it's not that there's an early effect and then it sort of dissipates. So that would argue for continuing to use the drug, but the expense of it is a point well taken. So it could be factors like the complexity of the revascularization. I mean, as Wayne was saying, you've got to look at the whole picture. What's the patient's risk of bleeding? What's the patient's risk of having thrombotic events? Yep. And, is this a redo peripheral vascular intervention that was difficult, or one that was maybe not so much? And then maybe you make the decision that way. But certainly this does not tell me that every single patient should be put on rivaroxaban.
Thank you. Thank you very much, Lynne.
I think this is another example, just as Dr. Batchelor said, where even though we can't rely on subgroups, we have to recognize that there are different patient populations with different risks of vascular events and bleeding. And we have to balance those for an individual patient in addition to the cost of the medication as well as the cost of bleeding.
Sure, Michael.
Well, I agree with the other comments that this is not one size fits all by any means. And if you look at the potential benefits, modest at best, it was kind of equally divided between ischemic events in the periphery versus systemic events in patients with peripheral vascular disease that are prone to stroke, MI, et cetera. And if you just look at the patients with acute limb ischemia, amputation, acute revascularization, there is a mild benefit, but not dramatic. So I agree exactly with what Ann said, that if you're going to treat patients with rivaroxaban, it would be in those patients who are at highest risk for subsequent ischemic events in the extremity. And those are reoperative procedures, extremely poor peripheral runoff, et cetera.
Okay, thank you very much. Actually, the third session is interesting. Ticagrelor, clopidogrel, aspirin, you take it. So let's move into the first study of this first session that I have, the TALOS-AMI study. This was entitled Ticagrelor or clopidogrel in stabilized patients after acute myocardial infarction. So it's basically what happens after the first month. And let me go back and perhaps go over a little bit of a background, which is important. So today, in acute myocardial infarction, in patients undergoing PCI, the current guidelines preferably recommend during the first few months or so for the use of ticagrelor or prasugrel versus the use of clopidogrel. And but there's an issue of bleeding, and it must say that in a number of clinical practices, in fact, they don't use ticagrelor or prasugrel. In fact, they use clopidogrel, and there are issues for that, and the bleeding risks, economic reasons, side effects, sometimes dyspnea with the use of ticagrelor. So but there are no trials that have actually done the clear study, and that is during the first month, you treat the patients as you should treat them, you know, with the appropriate medication like ticagrelor and aspirin, let's say. But what do you do after 1 month in patient with an MI who actually undergoes PCI? This is the critical question. This was an open label study done in South Korea with 32 institutions. And to go into the details of the study, these patients received in the first month aspirin and ticagrelor, and then they were randomized after that into clopidogrel or ticagrelor. Both had aspirin in addition to clopidogrel plus aspirin versus ticagrelor plus aspirin. And again, this is a little bit against the guidelines. Clopidogrel is not being used. I just want to emphasize. The primary endpoint was the composite of cardiovascular death, MI, stroke, and then bleeding 2, 3, or 5 of the BARC criteria. The number of patients that entered into the trial were close to 3,000, and they were randomized, as I mentioned. And then the question is, at 1 year, what about the primary endpoint that I discussed? Well, was 4.6% in the clopidogrel group versus 8.2% in the non-clopidogrel group, in the ticagrelor group. Frankly, I found this surprising, but that's what it is. And then when you look at what really made the difference in favor of clopidogrel, and in fact was the bleeding aspect, particularly of the endpoint. But certainly what it brings to us into the conclusions that is in a stabilized acute myocardial infarction patients, stabilized means after a month, and guided de-escalation of platelet therapy, and that is the use of clopidogrel, certainly significantly reduced the risk of net clinical outcomes. And thus was basically mainly related to the reduction of bleeding events. It's an interesting study, and I like to, Michael, what do you think about the situation with the going back to clopidogrel when in fact we were very aggressive in these patients after MI?
So I'm not 100% sure what to make of this, to be honest with you, because you're right. We had gotten away from clopidogrel with this. But I think, as you said, the data is the data, and there are higher incidence of bleeding rates with ticagrelor. So that I think that the takeaway message from this is to go back to clopidogrel in stable patients after a month.
Lynn?
Yeah, I completely agree. I'm always happy when less is better. But I would point out just to be careful of those patients in whom you have concerns about conversion, because clopidogrel is a prodrug. It needs to be converted to work, particularly for people who have liver function concerns. But other than I completely agree. It's nice to know that we don't need the stronger drug with more bleeding.
What do you think, Wayne?
You know, interesting. First of all, when we're looking at these de-escalation studies, and we tend to use non-inferiority analyses, we just have to be careful about the assumptions around the non-inferiority margins. The good news is that even in the ischemic endpoint, it looked like clopidogrel looked to be as good, or even slightly, the point estimate was slightly better, not statistically significant. It was all, the net effect was driven by bleeding. We know that historically that clopidogrel is associated with slightly less bleeding than ticagrelor, so that's not surprising. What surprised me in this study is that it was done in Korea, and Koreans historically are more likely to have CYP2C19 loss of function alleles. So it's actually kind of fascinating that that clopidogrel looked to be working as well, if not even, you know, as well as ticagrelor, and had less bleeding. It's just fascinating to me, especially within this population. So I wouldn't say that this is enough to completely change our guidelines, but it certainly is thought provocative, and I think it'd be nice to have some more data in other patient populations.
Significantly cheaper though. I mean, to me, if this is correct, the impact is very significant because
Yes.
in middle and low income countries, you know. But
Yes.
anyway, Anne, what do you have to say? Thank you.
Well, it was interesting to me that the two curves really were superimposed very early on. So it wasn't that there was any superiority apparently with ticagrelor early on, although certainly there are plenty of other studies that have been done that have in the past that have pushed people to use that drug earlier on. But the fact that the bleeding was less over time, I agree with you that having an inexpensive drug to use like that and having the outcomes be less bleeding, but no worse in terms of ischemic outcomes. It's a cheap drug and it's great to use. I guess the only other concern would be that since this was a Korean study, how generalizable is it to other patient populations?
Yeah, that's true. But
I do also always have a concern when we're assuming that patients are coming back regularly at a month. I worry if we look at this too much that people may end up getting sent home on clopidogrel instead of ticagrelor, just because, I'm not sure when they'll come back, et cetera. So we need to be careful and look at the circumstances and the timing of the study.
It's interesting because it was a non-inferiority study though, but they ended up in the conclusion saying it's superior. So, okay, Wayne, I think you.
One other very brief comment. Look at the ischemic event rate. It was 2 to 3%. That's pretty darn low. So the other cautionary note is just recognizing that in higher risk patients, I'm not sure that we can draw this kind of same conclusion.
Well, talking about South Korea, let's now move into the next study, which is what do you do in these patients when after a year? This is a different story. And what we do usually, we put the patients on aspirin, and then the rivaroxaban, the 2.5 milligrams is coming into the game and so forth. But let's move into this study, which is interesting, is the host exam study. The host exam study, aspirin versus clopidogrel for chronic maintenance following PCI. So this study was presented also by the group of South Korea. And I would like to first of all, to go into some details. Well, as you know, we have used platelet inhibition following 1 year, different types, but still aspirin has been the leading on that particular approach. And there is very little data comparing aspirin and clopidogrel after 1 year of PCI. So having said this is the study that tried to address this issue, also from South Korea, and I will describe the study as follows. This was also an open label. I say that because open label, can also always be some bias. This is why I mentioned. There were 37 study sites in South Korea, and the patients enrolled were patients at least 20 years of 20 years of age who maintained dual antiplatelet therapy without clinical events for 6 to 18 months. So it's all after that. And after that, the patients were randomized into clopidogrel versus aspirin monotherapy for the following 24 months, so it's a good follow-up. And the primary endpoint was a composite of all-cause death, non-fatal MI, stroke, readmission due to acute coronary syndrome. and then the bark bleeding 3 or greater. I want to emphasize that these patients actually, 25% were stable from the PCI point of view, and 75%, 2/3 were non-STEMI, acute coronary syndromes, and 1/3 only were STEMI. So it was a mixture of patients. And these were the results in terms of primary outcome at 24 months after the randomization. The number of the primary outcome occurring 5.7% of the patients in clopidogrel versus 7.7% in the aspirin group. Surprising? Maybe not. If you go back to the other studies done in the past, clopidogrel appeared to be superior to that. But this is basically what is telling us that maybe we should think on clopidogrel again after the patient underwent the first year or with the after PCI. And I'd like Wayne perhaps to give us your feeling about it, or how significant this data is. What is the impact? Because aspirin is much more manageable.
Yeah, thank you, Dr. Fuster. First of all, congratulations to South Korea for contributing substantially to the evidence base this year, first of all. Second, this is an interesting study. I think it's helpful. We have the Capri data that's from the 1990s, a 19,000 randomized head-to-head study comparing clopidogrel and aspirin in terms of ischemic endpoints and also looking at bleeding. And that study showed superiority of clopidogrel over aspirin. It was a very modest reduction. It was only 0.5 absolute risk reduction and a little less than 9% relative risk, but it was statistically significant and it was associated with less bleeding. So we already have pretty good data to suggest that chronic therapy, single antiplatelet therapy suggests that clopidogrel may be superior, and this supports that same contention. So, clopidogrel is generic, and so I would say that this is helpful. I think aspirin causes more GI bleeding, and if we get both a slight reduction in ischemic endpoints and less bleeding, I think it's a win. So this is helpful. It's not going to change our practice immediately in the United States, but I think it begs the question as to whether or not we need to consider this.
Lynn, it appears we are in the clopidogrel time. We had a previous study that after 1 month, you give clopidogrel instead of ticagrelor, and now you end up giving clopidogrel instead of aspirin. Is this, so tell what you think.
I think 6 to 18 months is a pretty wide window, and I think we need to recognize that. Interestingly, from my own experience with VADs, we used to put everybody on clopidogrel and aspirin, which we still do. However, as soon as they start having GI bleeds, we take them off the aspirin. So I think it's interesting to see this in other settings as well as just in the post-PCI patients.
Anne?
I think it would simplify things to just go with clopidogrel, after the initial period. So, I think it's interesting, and it's a great study. It's simple monotherapy with clopidogrel, and I think this may push more people over in that direction.
Okay, thank you very much. Well, let me go into session number 4. Interesting. We have a first paper. We are talking about the SGLT inhibitors in diabetic and non-diabetic patients with heart failure, with renal failure. But here in this particular paper, they try to compare, I don't know if it is apples with oranges, but basically it's a comparison of what is in the literature with SGLT2 inhibitors with the use of sotagliflozin, which is an inhibitor of 2 and also of SGLT1 inhibitor. So it's a little bit of a comparison in the literature, and frankly, in trying to summarize this, I will do the best I can, but I wrote here 5 points. So you follow 1 to 5, and I guess you will get a feeling, I hope, for what this is all about. Well, the first point is, if we go back to the SGLT2 inhibitors, canagliflozin and dapagliflozin, empagliflozin, and so forth, showed that improving cardiac and cardiorenal outcomes in patients with or without diabetes, and in some with heart failure and others with chronic kidney disease. We all know this. But now comes this drug, the sotagliflozin, which is an SGLT2 inhibitor and is also an SGLT1 inhibitor. And this leads to my second point. What is the difference? Well, as you know, the SGLT2 is in that receptor is certainly in the urinary tract and prevents the absorption of well, it works into the glucose transport, whether the SGLT1 is in the glucose transport on the small intestine. There are differences. Now, what SGLT1 makes the difference here? Because what the paper is trying to say is that the sotagliflozin may be superior to the other because it affects is a 2 inhibitor and is a 1 inhibitor. Well, let's now go into the real data. And this is the point number 3. What is basically happening here is that they made a comparison of the different trials with SGLT2 inhibitors that we mentioned before, with the 2 studies recently published in the New England Journal of Medicine with sotagliflozin. And in these 2 papers, again, recently published, and I want to give you the, at least the synthesis. The first paper was sotagliflozin, a GLT2 and GLT1 inhibitor in patients with diabetes and recent worsening of heart failure. And basically what they found is a lower total number of deaths from cardiovascular causes and hospitalization and urgent visits for heart failure when they use sotagliflozin versus placebo. This is the first paper. And the second paper, instead of heart failure, was renal dysfunction and also had a positive result. Then what it has been done here, and I think Deepak Bhatt presented this, what it has been done here is to compare the data of all these studies done with the SGLT2 inhibitors with these 2 papers that I just presented of the New England Journal, which is SGLT2, SGLT1 inhibitor with sotagliflozin. And this is what they say. What they say is, this is very good drug. Why? Because when you look at the number of events, this sotagliflozin not only was helpful as it was the SGLT2 inhibitors into the endpoints we mentioned, but is much better in terms of myocardial infarction and stroke and in decreasing hemoglobin A1C in patients with renal dysfunction. So what they are doing is comparing all the data with the SGLT2 with this one, and now they put together, and it comes that maybe there are less events or strokes and myocardial infarction in the group sotagliflozin. I feel how I feel confused because you're comparing apples with oranges here. I don't know, Lynn, what you have to say, but let me finish because now I am in point number 4, is the next one. And that is, what is the explanation? And here there are several explanations are being given to what is happening. First of all, this SGLT2, SGLT1 inhibition, glucagon-like peptide increases. And we know this can have some significance in favor in patients of heart failure. And then there is experimental data that hypertrophy myocardial fibrosis with SGLT1 inhibition may be decreased, experimental data. So there are reasons one may think that this is better. And the adverse events were practically the same. So this is the conclusion, and it is my final point, point number 5. In addition to a reduction in hemoglobin A1C levels in patients with advanced kidney disease, I mentioned this, and in diabetes, the relative increase of SGLT1 inhibition with sotagliflozin may provide greater protection from MI and stroke than the current available SGLT2 inhibitors that provide a lesser degree of SGLT2 inhibition. These observations suggest that dual SGLT1 and SGLT2 inhibition may provide an advantage over existing therapies in patients with diabetes mellitus. All these patients actually were compared, they were all diabetics. Lynn, how do you react to all of this?
Oh, I have very much your same confusion. This took me a long time to try to figure out where these people came from. I think the first question is it different than the ones that are just SGLT2 inhibitors? I think certainly they're more likely to get a ongoing fluid loss in people with renal dysfunction with this. I don't know about the other mechanisms. I am also just very bewildered by taking people who had worsening heart failure and diabetes on the one hand, people who had stable disease and renal dysfunction on the other, and putting them together. Those are two stable and unstable heart failure, two very different situations. And in fact, in the heart failure, the worsening heart failure, the minority of people had a preserved ejection fraction. So then to come together and say this is a drug for HFpEF, I actually think it is. I'm not too bothered by the conclusion. I'm more bothered by the route to the conclusion than I am by the conclusion. I think this is a good family of drugs. Clearly, it remains to be seen if this one is better than the other ones. I don't think we have data for that yet. But I do think that we should be just a little stern about the mix and match approach here and what we can conclude from it.
Thank you, Lynne.
Well, I'm glad Lynn explained things to me because I was confused by the whole thing too. So, there's obviously we've got very good trial evidence now about the SGLT2 inhibitors and their effects in cardiovascular disease. So I think, all of us should be using them more. I couldn't have followed the analysis very well, and I have some concerns about it. But I think it's an interesting addition to our armamentarium for treating these patients.
Michael, you are not confused. Just tell us the truth.
No, I was totally confused, and now I feel better. I thought it was just a surgeon not understanding all this. So I'm glad to hear that Ann and Lynn were confused also. But what was obvious to me on the front end, as Lynn's alluded to, is it wasn't clear to me that this was poolable data. There just seemed to be so much heterogeneity here. And the other thing I would say is that, the benefit of SGLT2 inhibitors seems so great nowadays that you almost wonder whether it's going to be in the water like fluoride. But I was heartened to hear that there was a trial that showed that SGLT2 inhibitors didn't work for something, and that was COVID. So I do think I'm totally supportive of this class of drugs, but we should be discriminating and cautious.
Thank you, Wayne.
Yeah, not much more to add to that. The only other thing I would say is it's going to be time for clever people writing guidelines to assist the average cardiologist in understanding when to use these drugs, which drug to use, and what the totality of data suggests. So I think this is a call to action, obviously, for the guideline folks to help us sort this through and come out with something. I don't know if Lynn or Ann have any hints on when.
I do want to mention that for most patients, we're talking about $500 a month for each an SGLT2 inhibitor and sacubitril/valsartan. This is really, really expensive, and most patients can't afford it. And I don't think we're in a position to be able to tell them exactly why they should afford it if they also want to eat and, send their kids to school. So this is a problem as a healthcare system. It's fine to come up with things that work, but we're going to have to be able to deliver them without such a price tag.
Okay, thank you very much. The challenge of today, we have 6 minutes. So let me go into the last study. The last study is the GALACTIC-HF study. It is effect of ejection fraction on clinical outcomes in patients treated with omecamtiv mecarbil in the GALACTIC-HF. John Turling from the University of California, San Francisco presented, and here's the introduction. And I think it's true that none of the studies that we know today in heart failure and inotropes, actually the ejection fraction improves. The patient improves, but not necessarily the ejection fraction. So here we have these new type of drugs, the myotropes, that actually work in the cardiac sarcomere, enhancing the action. And one of them is, the first one actually is omecamtiv mecarbil. Now, here's the story. This is the COSMIC-HF study, in which, in fact, this drug was used, and it seemed that increased ejection fraction in that study, but there were no outcomes. On the GALACTIC-HF study that was just published, there were outcomes, and this drug improve outcomes in patients with heart failure and reduce ejection fraction. What now is done here is to present how good it is with different ejection fraction. This is really the study that is presented, the GALACTIC-HF study. And to make the long story short, since I don't have much time, I will tell you that it works better with the low ejection fractions, less than 25%, and it doesn't work too well with ejection fractions above 35%. And then you have everything in between. So in summary, it's an interesting type of drugs, and lower is the ejection fraction, better is the way the drug works. Lynn.
I agree completely. And I have to say, I think it's really unfortunate that they didn't target these patients with the lower ejection fraction and the higher likelihood of benefit, because there's not much enthusiasm out there for this drug, but we really need drugs for patients who continue to be symptomatic despite all the other therapies we have. And I think by casting the net too wide, they may basically have lost the fish in this one, because I do think it helps.
Thank you. Anne?
Well, yeah, I mean, and when you have patients who have that level of depressed ejection fraction, how many other options do you have? I mean, at that point, we've put people on all the drugs that we can. So to have something like this for the patients who were the worst off, you know, there's a niche for this.
Thank you, Michael.
I don't have anything to add to Lynn's and Ann's comment, Valentin.
Well, you don't send the patient for transplantation. Just send it to Lynn or to Anne.
Right.
All right. So, Wayne?
Yeah, not much more to add to that. I think it's fascinating that we're seeing now a class of drugs that increases cardiac contractility and actually reduces heart failure and without an adverse effect on mortality. So I think that's exciting, just as the general cardiologist looking at this, and I have nothing more to add.
Final question to each of you. Think for a minute. Which is the study presented today out of the 8 that you feel most excited? Michael?
Well, I've got the surgeon bias, so I would say LAAOS 3.
Lynn?
I like the Galactic, but I'm afraid the message won't be picked up. I think on the other side, the Paradise was very important in showing us that we have to look at our patient populations and not give one drug to everybody.
That's a good point. Anne?
I like LAAOS 3 too, as well, because it's patients that I see with atrial fibrillation. And so I think it's a fairly simple additional thing to do during surgery that has a positive impact. So I think that's probably going to be one of the most impactful studies out of the ones we talked about today.
Wayne?
Yeah, I would agree with both Anne and Mike on this. I think LAAOS was a fascinating study, and it really, starting tomorrow, I'm going to just remind my surgeons to just think about closing that left atrial appendage if they're in there for another reason. So it's impactful.
Yeah, what I learned is that aside of LAAOS, what I learned is how we should look at trials and be very critical. A number of issues have been discussed today, which I think are quite important in terms of what a trial means, how it is designed, what kind of statistical methodology is being used, what is the actual impact, relative versus absolute. And I think the studies that we had today, 8 studies, in each of them there is something of this, and I think that to me is educational. Well, look, this is fantastic. I'm obliged to invite you again in the next time because you did so well, and there have not been any fights. This is the only problem I found in the meeting we had today. So you guys have been very homogeneous in terms of your views. Thank you very much to all of you. I think this is a good hour, and I hope to see you soon again in a similar format. Thank you.
Thanks, Valentin.
Thank you.